Take it away, Mike.
Thanks, Judy, and good morning, everyone, and thank you for signing in. Those are my conflicts, which really don't have anything to do with this talk. I'm following three great talks by Danny and Celine and Chris, and I'm just going to kind of summarize things in my experience. And this is an uncommon injury. It's a very small section of the fractures we see, but if you miss it, there's a very high incidence of degenerative arthritis. All of you know the anatomy, but for those extenders who are here, this is the key, the interosseous ligaments of the Lisfranc joint. And you see that there's one that's really the key, which holds the first and second columns together, and it's very thick on the plantar aspect. Now, we talk about in the textbooks, you see about direct blows and crush injuries, but what we're really interested in certainly a sports world, is this twisting and axial loading of a plantar flex foot. And then in the NFL, there are a lot of non-contact injuries that develop from just the force that these players put on this joint. The injury can be somewhat subtle, as you see on the x-ray, and we're going to look at a lot of x-rays because that's where mistakes happen, but you can spread it intraoperatively, and you see that tear of the Lisfranc ligament. Now, and you see that also that if you get advanced imaging, you'll see a defect there in the Lisfranc ligament, and you see that instability that you see on the movie as well. Now, we're talking about subtle injuries in this case. It's this one, then you aren't looking at things very closely. I think anybody would appreciate this. But approximately 20% of Lisfranc injuries can be missed and lead to a significant sequela. And you have to really start by history, just listening to the patient and touching them. How much did it swell? That's a major league question, because if it's a watermelon foot, probably something big happened, and you need to have sort of your antenna up. This never made it to the orthopedic surgeon initially, and you see these fractures of the second and third metatarsals in the previous distal first metatarsal osteotomy. And it was sent out in a cam boot and then came back about a month later, and you see that there was an obvious Lisfranc injury, but if this foot had been palpated and they talked to this patient in the emergency room, they would have appreciated it was a much more significant injury. So you have to say to yourself, is there unexplained a lot of swelling, or is there bruising? And that just gets your antenna up as well. Nothing beats palpation of the foot and tenderness and just palpating the whole foot, and even do a passive pronation abduction test. Now, your imaging, your first image is really helpful, but it may not be that helpful, but that's obviously where you start. You may see nothing on the left. You may see a little spread, that little flex sign that we see here. This is from our Tech and Tom Clanton's chapter, and you see there's a non-weight bearing x-ray on this patient in the middle, and then you see how the first and second columns are split in a weight bearing film. So getting more information is extremely helpful as well. Now, plain radiographs, you may see something obvious like you see on the left-hand side, or you may see just this little fleck on the right-hand side that still is a significant injury to this foot. I think you can also look for the alignment between the second metatarsal and middle cuneiform, or down in the bottom, you can look between the cuboid and the medial border of the fourth metatarsal. These are all things that help you to realize whether there's shift to this foot. And be really wary. It can split actually between the first and second metatarsals, but between the first and second cuneiforms. And you just have to look at these. Another helpful step is just a stress radiograph. This is under anesthesia. If you did this to somebody in your office, they would probably kill you. But then you do advanced imaging. And now with this, you may see injuries that you didn't even see on plain x-rays and with these fracture patterns. And this will help you to decide what the ultimate treatment will be. I think also SPECT scanning can be very helpful. Wondering why this person is swollen and you don't see anything. And of course you get a CT with it. Normal x-ray, but pain. This was a basketball player at our local university, and he hurt and he sprained his Lisfranc joint, and we could see that he had some instability or some ligamentous damage, but not a lot, and we could go ahead and play him with an orthoses and actually not treat him aggressively. But with MRI imaging, you can see that area between the ligaments action of the first and second cuneiforms and the first and second metatarsals and the Lisfranc ligament as well. Now, treatment, you've already heard lots of different treatments, and everybody's going to be on different sides of the aisle here. But from a standpoint of exposure, you make that exposure in the first and second sort of interspace. You expose the EHL and EHB, make sure you see the neurovascular bundle, because all of these things you can learn from your mistakes, and you don't want to injure these as well. You then obviously will place a perk screw most likely, and you may need another incision to basically see lateral joints if indeed you have a more extensive injury. Now, on the soft tissue reconstruction aspect of this, you certainly protect the neurovascular bundle, but you may actually repair the ligaments, and in subacute cases without arthritis, consider reconstruction of the Lisfranc ligament with either an allograft or some other type of tissue repair. And for example, in one of our talks, we see the original treatment that people did with a cross couple of screws and then K-wire fixation of the third tarsal metatarsal joint. Tightrope fixation has some advocates, and for just a pure ligamentous injury, you certainly don't have a screw crossing that area that can fracture. This is a ligamentous injury on the left compared to the right, and you see that screw fixation was placed across the first cuneiform, metatarsal cuneiform and intercuneiform joint, but then a tightrope to stabilize the Lisfranc ligament area. You see on the left a obvious instability pattern, and you see the K-wire fixation initially. Now we see as we develop the screw fixation, and then we will go ahead and put a perk screw. And this has a bridging plate over the first MTC joint. That will probably be taken out at a later date, but we're trying, in this case, to avoid any significant cartilaginous injury. I'm going to show a couple of extensive injuries. Sorry for the x-rays there, but these are significant fracture situations. Now, some might just do a primary arthrodesis here. In this case, this patient was treated with an ORIF. Here's another significant injury that you would see treated with multiple K-wires to initially reduce the fracture, and then internal fixation of the first three tarsal metatarsal joints. Joint preservation has been the biggest sort of step in the new thinking of Lisfranc injuries, and certainly if you do that, spanning plates are how you're going to treat this, and that obviously will eventually require a plate removal, but you can do these with minimal osseous injuries. Now, I want to go through, this is actually Bob Anderson's postoperative protocol, and he's going to be on our panel, but didn't get to give this talk, so I'm going to give him credit for this and just say for the rapid recovery of these patients, a short leg splint for 7 to 14 days, and then you move them along to full weight bearing at 4 weeks if you have good fixation. And then he mentioned, and we'll probably talk about this in our discussion about screw removal and possibly an endo button, just to control sagittal plane motion, and then you move into more rehabilitation and return to practice when strength and agility allow that to occur. Now, from the rehab protocol, you start with exercises right away so that they don't really get detuned. It's important for the athlete to be given some form of exercise, even if it's upper extremity or well leg exercises, just to keep them in the game. And then as you move along using an Ultra-G treadmill, running straight line, then cutting in agility and jumping, and then back to practice, and using an orthoses or carbon fiber insert. Now, the complications that we see include neuroma. We talked about that. You got to be careful with your dissection, loss of reduction with late diastasis, broken screws, and late arthritis. And I just show this case, maybe not a great reduction. And you can see there's the broken screw. It was later removed, and that is not an easy case, I can tell you. Not my case, but I appreciate having this case to show, and then an endo button as a salvage. But lastly, I want to conclude with just talking about the Lisfranc injury, purely a ligamentous injury, but a primary arthrodesis. And I think two people deserve a lot of credit, Chris Coetzee and the Grand Rapids guys, Don Bohe and John Anderson. And these are very interesting cases that they just did a primary arthrodesis. Now, that may not be an athlete. That may be somebody who you go, there's certainly articular injury, and you just want to do one and done if you can. So a primary arthrodesis is certainly something to consider. But I can tell you that in the real active athlete, that's probably not going to be your deal. But just like calcaneal fractures, you're trying to avoid a two-stage surgery if you can. And if you have a really injured joint, then you may want to do a primary arthrodesis rather than do this as you see on the left, remove the hardware, and then do a secondary arthrodesis, which would be 3 different procedures. So steps 1 and 2 are really unexplained midfoot swelling, midfoot tenderness. Don't miss this. Lastly, plain radiographs, then go to stress radiographs, and then finally advanced imaging. And the alternatives treatment, ORIF and bridge plating, or an arthrodesis. Thank you. Thanks, Judy.